So Jackie, you know, former, right? You know, my last name.
Former. I know. Thank you so much for doing this for us,
Of
even
course.
though you've escaped. But yeah, whenever you want to get started, we can see this and
Sure.
hear you perfectly.
Yeah, sure. So I just want to encourage everybody that if you do want to ask a question, just feel free to interrupt me. This is quite informal. This is a lot of history heavy. I kind of wanted to go over a little bit of our historical backgrounds into how sort of we ended up in a very, in my opinion, a biased healthcare system towards certain patient populations. So if you want to interrupt me and ask a questions or ask a clarification or just to give your opinion, please feel free to do so. In fact, I prefer it. And with that, we'll get started. So to start the lecture, I wanted to ask you guys if anybody knows how long it takes for research to translate into clinical practice. Does anybody have an idea? Is there like a chat function here that I can use? I'm not really good with this
So
texting
people can
situation.
unmute themselves, or you can post in the chat. I can
Yeah.
the chat as well.
Yeah, if anybody hasn't, you know, from the time we, do an experiment into the time this translates to us actually, practicing this in our hospitals or in our practice, how long would you say, more or less? Almost 20 years. Yeah, I mean, yeah, something along those lines. It's close to 10, but it takes a very, very long time for clinical or for basic science to translate into clinical medicine. So we'll get started on that, and you guys hopefully will understand where I'm going with this. Okay. So we'll get started. So, the reason why I wanted to talk about this is because I do think that, one, we're all in a very super diverse community. We are, at least at Morningside, the majority of our patients come from the Bronx or Harlem. We deal with a lot of patients from, either African-American descent or Latin patients from South America or the Caribbeans. And I think it's really important for us to understand a little bit about the mistrust, I suppose, that we've had with these patients. I think the pandemic that we've been through and still going through have really demonstrated a lot of this distrust that many patient populations have towards the medical field. And, for many of us younger doctor, we may not quite understand why this happens. So I think that, what I wanted to do with this lecture is go into a little bit of the history about that. If you look back at textbooks and historical textbooks, medical anthropology, most of the times we discuss when researchers were researching science and human, most of the time they were researching men. So women were excluded from this, so were children, so were people of color. The rest, everybody was an extension to white men, right? And, when we talk about sciences, we really talk about Western sciences, because that's, most of the medicine that we know right now sort of, comes from that, I mean, we can debate that for a while, but, more or less. And, so the people that were studied, we're talking the 1800s, we're talking the early 1900s, were mostly men, mostly white men, and the rest of us were an extension to them. So there were really never any early studies that were done that talked about women, children, people of color, etc. Why is this doing that? Okay, so in 2020, the US Census estimated that 33 people in the United States identify as members of a racial and ethnic group that are underrepresented in medicine, yet only 6% of the people that perform research in the United States come from those groups. And only 4 to 5% of people participate in any sort of, drug research, et cetera, come from those underrepresented groups. So there's a big disparity between the people that claim to be from underrepresented minorities in America and those who actually get to represent them in research, whether on a researcher level versus on sort of an experiment subject. So how did this whole thing begin to change, or how did we even start to understand, because when things are ingrained in history, it's really difficult for many of us to say that something is wrong or something is right. Even for me, when I was sort of doing this research, there were many things that I got to learn that I, thought it was right, or sort of it was ingrained to me because I was taught by, majority of my teachers were men, that they were right. So how did this thing change, and how did we sort of start to look into what was done right and what was done wrong? And obviously most of the changes, at least in my opinion, start with the women, and today is International Women's Day. So I think it's very suiting to give a shout out to all the women. In 1977, the FDA recommended excluding women from phase 1 and 2 of clinical trials. So basically they said, we are not including any women in any of the phase 1 and 2 trials because we want to make sure that they are protected, right? So even if the women had consented to the research, the FDA said no. And obviously, I'm not, no good things ever, come from that. And one of the biggest things that we, in modern medicine know about is the cases of thalidomide. There were many children born with limb defects because their mothers were taking thalidomide as a medicine. And obviously this medicine is no longer used in the United States, but mostly because of the birth defects that it would cause. But because women were excluded from the research, nobody knew about this. And unfortunately, once it became a drug that was widely used by women and men, unfortunately, all these birth defects came about. So in 1986, and again, this is not a long time ago, the NIH created a policy that encouraged, right, researchers to include women. In 1990, the NIH investigated, they were investigated for lack of commitment to really include any women in their research. And in 1993, there was a law, it's called the Women and Minority, it was a law, it was a public law 103/430, you can look it up. Women and minority are subjects in clinical research. And that was the first time in the history of the United States, 1993, pretty much just about as old as many of you, or even, younger or older. That was the first time where it became a law to include women in research. So if we think about all these medications that we use, everything that we know about heart disease, when we know the movement for the PCA and the angina, blah, 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 all these medications, this stuff, this precedes 1993. So many of what we still know and practice comes from the 80s and the 90s. And, when this law was passed in 1993, there's still many, many years to come before women were to become included in research. So, and again, this law was mostly focused on women. Unfortunately, this not necessarily translate to our Black patients in America and other minorities as well, minorities that are growing in the United States. So let's talk about, the purpose of this talk, as much as I would have liked to talk about women in medicine or women, women in medicine, I guess, in general. The talk today is to talk about the treatment of at least the biases that I think come from historical facts to our Black patient populations, which we have a significant amount of, at least on the Morningside campus. So I wanted to talk a little bit about the statistics, and these are all sort of facts, these are facts that we can't persuade. These are facts that we can't really say subjective, objective. These are facts, these are statistics. You can find them on CMS website or the CD's website as well. Some of the facts out there is that our African-American men have the worst health outcomes of any major demographic group, period, right? This is typically done while adjusted for college, for income, etc. African-American receive lower quality care in services that include cancer, HIV, prenatal and preventative care, and they're less likely to receive treatment for cardiovascular disease and more likely to get unnecessary limb amputations than any other demographic group, right? This is not an emotional statement. These are statistics or facts that come from CMS. And these are, the people, one of the governing bodies for medicine. Sickle cell disease has received less attention than any other less common diseases that affect a single gene mutation. And the opioid crisis, did not spread in the Black community, despite the war on, the war on drugs that really affected them. But the opioid crisis really spared the Black communities in America. It was mostly in, white suburbs, the majority, at least, of the opioid crisis. Black patients' care is better when the doctor is Black. And Black patients receive 34% more preventative care when the doctor is Black, yet only 4% of all doctors are Black and less than 7% of recent medical graduates are Black. So the disparities are just massive. And it's been proven time after time that when Black patients have a Black doctor, they just do better. They get better care. And I think that's a moment for all of us to sit here and reflect on our practices and just think about the things that we could potentially do right or wrong. And again, if anybody wants to interrupt me, please feel free to do so, because I know people get very emotional about these topics. Good. Okay, I still have to figure this out. Okay, so let's talk a little bit more about these statistics. So I'm not going to get into all the numbers. It took me a while to come up with these numbers, but I'm not going to bore you guys with all the teeny tiny details, although they are important. But you know, in general, African American or Black patients are, you know, there are more uninsured patients compared to white or non-Hispanic patients. They are more likely, you know, like I said, more likely to not have insurance, more likely to have health or government health insurances. They likely to have more chronic diseases, or report to have poor health compared to non-white or Hispanics. 80% of African American women are overweight or obese, compared to only 64% of non-Hispanic white women. More African American or Black children have asthma than any other race. 42% of African American or Black patients have, over the age of 20, have hypertension, compared to only 28%. And in general, Black people live 6 years less than their white counterparts, right? You know, all these, you know, we can get into all the tiny details of every single disease, but they just live less. They live 6 years less than their white counterparts. And I think that's huge. So there, you know, there was recently actually a Medicare population study of about 40,000 patients with AFib. This is just some tiny examples of things that we personally do every day, right? You know, they studied about 40,000 patients with AFib, and they saw that Black people were 20% less likely to receive a DOAC, right? These are medications. I mean, think about the times you prescribe DOACs to your patients. Think about the times that patient come to your clinic or come to the hospital and they're on warfarin, and you know, you kind of go like, oh, do I really want to switch to the DOAC and get the prior auth, blah, blah, blah. But you know, we are prescribing less of these better, for lack of a better term. I mean, I think they're easier to use, and just, you know, because of the less fluctuations than Coumadin, they are better and easier for the patients. Yet we're not giving them as much to our Black patients as we are to everybody else. And this, you know, this is also adjusted for insurance. So this has nothing to do with money. This has nothing to do with a copay. They studied patients from the same insurance plans, and we're still giving Black patients less DOACs than we are to others, right? So that's just something, I mean, I wanted to include this example because this is a medication that I personally prescribe. I know many of you do at least once a day, right? So, you know, and you know, it's just thinking about if there were ever any biases or ever any hesitancy or reluctance to make any changes or switches to people's medications. So these are just more statistics. The leading cause of death in African American populations are heart disease, cancers, and accidents. African Americans have the highest mortality for all cancers combined, compared with any other, you know, racial or ethnic group. There are 11 deaths or infant deaths per 1,000 live births among Black patients, compared to only 5.8 in every other patient population, which is about twice. So the infant mortality is just significantly higher in the Black patient population. So it's, you know, lots of disparities that, again, it's most of these studies have adjusted for insurances, for incomes, for college education. So to blame it on these other social facts is just it's a bit superficial. Maternal health is one of the biggest things, and again, you know, because of it is International Women's Day, maternal health has to be one of the worst disparities that we have in our healthcare system. Black women are 2 to 3 times more likely to die from a pregnancy than a white woman per se. I see something popped up in the chat. I'm going to pause. Okay, so pregnancy-related deaths per 100,000 lives for Black women older than 30 was 4 to 5 times higher. Right. So, I mean, I don't know, if I was a Black woman, I'd probably be terrified of coming to the hospital to give birth, because I mean, these statistics are just insane. Most of these deaths are preventable. Cardiomyopathy, a lot of pulmonary embolisms, hypertensive cardiomyopathies, a lot of these things are preventable, yet there are the leading causes of Black women older than the age of 30 in the hospitals, and they're significantly higher than their other ethnic counterparts. Again, more about women. Unfortunately, it seems to, the double minority seems to not benefit them at all. They're less likely, Black women are less likely to have breast cancer, but 40% more likely to die of it. They're more likely to die of heart disease, cervical cancer, and any maternal related complications, right? And these are all statistics. This is all we, straight from our practices. These are things that we participate in on day-to-days, yet, somehow these statistics are there. I'm not really sure why, and I guess we'll get into why. I'm going to fast forward through here. So the question, I guess, is how did we end up here, right? There's, I don't know if anybody has an idea how we ended up here. A lot of people will say, majority of Black patients tend to live in, impoverished areas, lack of access, et cetera, et cetera. But again, many of these studies were adjusted for insurances. Majority of it were adjusted for insurances. Not necessarily educational level, et cetera, but for at least for insurances, which for many providers, when you call to go to a clinic, I mean, insurance is what a provider really cares about for billing purposes. So, I'm not really sure if you can use finances here as a really a reason to explain it. Yet, unfortunately in medicine, we have created many biases. And, obviously, I don't think that our generation per se is the one that, was there causing these biases to become rampant. But unfortunately, I don't think many of us really looked into a lot of our practices and questioned whether it was necessary or not. And, and I guess like one of the biggest examples that I can think of here is, this whole, I mean, I wasn't trained, in my training, I mean, race was something you included in your HBI. 54-year-old Black female presented to da-da-da-da-da, which, if we think about it, why is that important, right? So, and that's the next question we'll get into. And I guess before we get into that, and this question I will answer at the end of the lecture, do Black people have thicker skin than white or light-skinned people? And I guess that's a question for all of you that I want you to think about. The answer is yes or no. I mean, do they have thicker skin or do they not have thicker skin? So I want you to think about that. And I, would like to see what everybody's feedback on it is. And we'll keep going. Goodness. Okay. So again, why is, where did this whole race thing come from? Why were we taught in medical school that when we're presenting a patient, do we have to talk about the race? Why do we have to say 54-year-old female, male, white, Black, Hispanic, blah, blah, blah? Why is that so important, right? And, if you really actually think about this question, it really stems from the concept that we are biologically different, right? That is how medicine is structured. We are biologically different. If you are Black and I am white, then we are biologically different. Therefore, the diseases that affect us are different. The manifestations are different. And, it's important to highlight. But is that really how we define race? And this is a question that I don't think to this day anybody can answer. And the real definition of race is really, there isn't one per se, but there are two definitions to race. One is a biological one, which is what we use in that's how we've been trained, right? Black, white means separate, means different, means we are genetically different. Versus a social construct, right? Which means that your race is basically based on where you come from, how you were raised, the area, et cetera, et cetera. And when it comes to the biological one, unfortunately, because we are, we don't have, I guess, DNA analysis in our eyes. When we talk about biological race differences, we mostly refer to skin color and facial features, which if you actually think about it, it's a pretty silly way to differentiate people, right? I mean, let's really think about that, right? I mean, there are people in India and Africa that have the same skin color. Does that mean they're biologically the same? Right? Same thing with, with lighter skin color. I mean, I'm super fair. Does that mean I have the same biological DNA or different, as somebody who comes from Ireland or anything, just because we have the same skin color? So unfortunately, our biological race, which is what we typically use in medicine, we really rely on skin color and facial features, which again, pretty superficial stuff, but yet unfortunately it was so deeply ingrained into our medical training that we use it to really, you know, do a lot of our, you know, do what we do, I suppose. So again, back to what defines a race. And we talked about the biological and the social construct, but I want you guys to just, you know, a little bit of history here, because I think this is really important. And, you know, when I did this lecture, I did it last year during the whole movement, you know, with the Black Lives Matter, when things got really rough with the police shootings and what have you. And I really wanted to talk a little bit about the history of how, you know, I mean, this whole race thing just, you know, just became to me just very outrageous, that I really wanted to look into, you know, all these issues that happen in our country, right? And, you know, believe it or not, up until the 80s, parents weren't allowed to choose the race of a child. You know, if you ever have a child, you actually get to choose the race of your child. You can call them whatever you want to call them. Honestly, it's up to you to determine the race of your child, right? But up until then, there was this one drop rule, particularly in the South, which if you had a drop of Black blood in you, that means, you know, you are Black. And unfortunately in the South, for a very long time, that translated to you not getting many things: healthcare, school, segregation, et cetera, et cetera, et cetera. So, you know, I mean, this really helped me reflect on a lot of the things, you know, particularly this whole like notion of race that had to be determined when we were presenting HMPs, because, you know, once I got to really think about it, I realized that it was just completely unnecessary, to be honest with you, mostly because it really stems from, I don't think, from very good places, because our, you know, understanding of race is very, very superficial, and yet we do make a lot of decisions based on it. So talked about these things. I'm gonna keep forward here. Yeah, okay. So why has science marginalized, like, you know, so you're going to sit there and say, okay, so why are we having this conversation? Like, why, what was the purpose of anybody doing this to people of color, right? And, you know, one thing to understand is that, you know, medicine, doctors, all of us, we don't really operate in a vacuum, right? We operate in the construct of the society that we live in, right? So if you were a doctor during the 50s or the 60s, these are, you know, you had some values that carried from the society that was around you, and you behaved accordingly, right? So it was definitely incentivized for, you know, for people to be separated, for, you know, oh, okay, if you have, you know, your GFR is lower, then you're not going to go for dialysis early on. You know, somebody else is going to go, you know, you're going to have to wait for your disease to get worse before you can get on dialysis, because technically your GFR is lower because you are Black, et cetera, et cetera. So, you know, so we're not necessarily saints. I think we operate along the you know, the social environment that we live in, and I think that's, you know, one of the reasons why medicine was not as innocent as far as creating biases for patients as well. Which is why, you know, again, reflecting on the you know, the vaccines and what have you, a lot of people in marginalized communities really refuse to get the vaccine because they just simply don't trust us, because they do have that notion from years of mistrust and treatment, really. So let's talk about those examples of how did we mistreat or misrepresented people from history. You know, there was a lot of articles talking about, you know, in the 80s or to the 1940s, talking about, you know, they were mentioning of the fertility of Black women have dropped. And, you know, at the time, the fertility of all women in the United States have dropped, yet only Black women were labeled as, you know, they had a lot of venereal diseases, and therefore their fertility dropped because, you know, they can't control their sexual desires, and therefore they became infertile. But nobody really talked about why also white women's, you know, fertility rates dropped. And I guess by fertility rate is the amount of children women were having in that era. I guess it had decreased during that time. You know, obviously this was taught to doctors at the time. There were doctors, I mean, you know, that lived in that era that believed that Black women had more venereal diseases than white women. They believed that Black women couldn't control their desires. And, you know, I pulled up actually some texts from some of these groups talking about, you know, just the inability of Black women to control themselves. And I mean, some of these things come from the 50s and the 70s, right? This is not, we're not talking about, you know, hundreds of thousands of years ago, doctors were racist. It's like, no, these doctors were probably, some of them taught us and taught our mentors, right? And, you know, and this is how these biases sort of go down history, I suppose. And, you know, this sort of made me wonder to, is it why, you know, is this why the maternal mortality is much higher in Black patients? Do we as doctors think that Black women are not as worthy of treatment or better or good treatment in the hospital because they're, you know, can't control their desires, blah, blah, blah. I mean, you know, if somebody wrote textbooks like this in the 70s, many of us were taught by people like this, right? Many of us, those were our OBGYN attendings, or there was their attendings that wrote textbooks like this, right? So sometimes these biases, you know, again, it's a bias. It's not an explicit, like outrageously racist statement, but it's just all these little things, all these little statements that we talk about that will translate to our practices. And it's clearly reflected in our practices because we do a horrible job for at least Black women in the hospital when it comes to birth control, you know, just giving birth and what have you. The father of modern gynecology, least, I mean, these words are so cringeworthy to hear. At least 3 women for 5 years and operated almost 30 operations on them without any anesthesia to repair. He was like, he's the guy that like invented the vesicular vaginal fistula repair, right? This is a common complication after pregnancy, at least at that time. And this guy, you know, perfected the operation or the procedure, but he did that on 3 women that he operated on with no anesthesia. Right, and he was, you know, I think he still to this day has a statue at Sinai because he's the father of modern gynecology. But the way he did it, I mean, this was, you know, he tortured basically 3 women for 5 years, and then when the procedure was perfected, he deemed that white women were not strong enough to withstand this. Therefore, they needed anesthesia if he were to repair their vesicular vaginal fistulas. And again, is this how this stemmed down to, you know, why the opiate crisis really spared the African American or the Black communities? Is it because we did not think that they would feel pain because their skin is thicker or whatever it is? I mean, again, really, when you sit down and reflect on these things, it makes sense. It makes sense sometimes. And again, we never really directly participate in this action, but it's all these little things that we hear from our mentors and the people that were above us, the people that taught us. It trickled down, and you know, we are where we are, right? And you know, I'm sure a lot of you guys heard about the Tuskegee, but it's basically, you know, in the 30s, you know, they experimented on 400 Black men from Alabama, and you know, basically, you know, gave them, you know, did not treat their syphilis. I mean, at the time, it was like you treated syphilis with mercury, but they did not give them the standard of care for syphilis at the time, and they let them sort of fester in the community. And this was leaked in 1972, and they terminated the study in 1972 and called it unethical. This is the reason, Tuskegee is the reason why we have an IRB, you know, why we have our IRBs now. Before the Tuskegee case, there, you know, you could just do whatever you want, basically research-wise, nobody would stop you. But because of this Tuskegee case, an IRB committees were created to make sure that doctors don't abuse their power. Right. And, you know, again, history have shown many examples of how we as doctors have abused our power. This happened to be one of them. And this is one of the ones that a lot of Black patients remember. And obviously, you know, for very good reasons, because this just, you know, literally happened less than 50 years ago. When AIDS happened, or when the AIDS pandemic was, you know, going through the US, a lot of Black patients refused to be treated. They refused to be tested because they were afraid that this was going to be another Tuskegee. And, you know, to this day, HIV care in Black communities is worse than any other communities. And again, it comes from the mistrust. They do not trust us as healthcare providers because of all these things that we've discussed, because of these many historical big incidents that happened that unfortunately doctors were at the center of and the cause of, per se. There was, more things onto how these historical facts translate into poor care care for our Black patients, right? You know, I don't know if you guys, I don't know if this is still taught in medical school, but the way I was taught that osteoporosis is a disease that affects the thin, white, fragile female, right? This is the only, you know, this is, you know, osteoporosis, right? And, you know, this study that became the standard of care for screening for osteoporosis, you know, while I was training, and I'm not that old at all, it didn't really account for weight, for diet, for smoking, for alcohol consumption, for exercise level. And all of these things, what this did is that we stopped screening our Black Latin patients for osteoporosis, or stopped screening them as much because they don't fit into the thin, white, fragile female criteria, right? And, you know, and obviously the study was later on debunked because of, you know, because of the reasons that we mentioned. But imagine for years, you know, doctors were not screening for osteoporosis in those populations. So that obviously leads to, you know, if you're not screened for osteoporosis, more likely to have fractures, et cetera, but we're not screening for them because the study said it's a thin, white, fragile female, right? And when you don't fit that criteria, then we're not going to screen you for a disease that affects many, many women after a certain age. So, you know, and again, you're going to sit here and say, oh, well, this is the past is the past. We are like woke people now, you know, we do things so much better. And obviously that's, you know, unfortunately, that's not true at all. You know, there recently, actually last year, the New England Journal of Medicine released an article on the disparity in the oxygen monitoring, the pulse ox that we use on all of our patients. And, you know, it criticized the study that made the pulse ox machine, or the technology that we use in our pulse ox machine, where basically when they looked into the data of that pulse ox machine, all the patients that they use, the majority of the patients that they use were fair-skinned patients. Which this, you know, and then, you know, so once this was discovered, they did 2 cohort studies that saw that there was occult hypoxemia in dark-skinned patients. Again, this is not black and white, you know, a race thing. This is a skin color thing. When they designed these machines, that the patients that they studied was a heterogeneous patient, or, you know, subject population, we shall call it. So when they rolled this out to the general population, the cohort studies found that there was occult hypoxemia, meaning that the machine would pick up that your oxygen is okay, when in fact it's not, it's lower. And could we say that this potentially was one of the reasons why Black patients did worse during the COVID pandemic? Because we would think that their oxygen was okay, but in fact it was not, because the machines that we used was designed on a heterogeneous subject population. I mean, could that be one of the reasons? Obviously, there are many reasons, and I don't want to get into the COVID stuff because I don't think that, you know, I mean, there's a lot of articles and a lot of data, but I don't think we have a concise understanding, but we know that there were a lot of disparities depending on the community that you came from. But just a simple technology that we use every single day, you know, which we never question, we just think it works, we think it's great because somebody told us it was, you know, you realize that when they designed these things, they were designed on a heterogeneous patient population. So, I mean, this just, you know, this just makes you think about everything else that we do. Like, was this done with the right intentions? Were these things done during, you know, keeping in mind the diverse, you know, population that we have in the United States? I don't know. I mean, there's a lot to think about here. And in addition to all of this, you know, the New England Journal of Medicine, I think, has been doing a phenomenal job over the past few years about talking about racial biases and equity in medicine and what have you. But they released a list, and I usually actually have a handout of this, but not in person. But there's a list, there's a huge number of algorithms that race is actually one of the points, I suppose, that you check off in the criterias. I mean, one of the biggest one that we as medicine folk, I mean, a lot of them were CT surgery, urology, hematology ones. But one of the ones that we deal with mostly is the GFR. And, you know, you check off, basically, if you are Black, you have to check, you know, one of the points is Black. So if you check that off, it gives you an extra point. So it exaggerates your GFR and makes it higher than it actually is. And, you know, most of these algorithms, if you are Black, then it doesn't make you as sick, right? So you don't look sick enough for you to, you know, require dialysis, right? But also on the other side, if your GFR is higher, you're also getting medications that potentially could be nephrotoxic, right? But because your GFR is higher, right, you're technically eligible for these medications. And unfortunately, all these algorithms sort of, being Black either makes you too sick to get the procedure or not sick enough to go for it. So it's, these are things that we use every single day. To this day, doctors still think that Black is very biologically different than white, that we have to put it in a criteria and give those criteria a point, plus or minus, whichever direction, obviously. But this really, it makes me really think. I mean, do we really think that it's that biologically different? I mean, who's making muscle analysis on Black patients and calling it higher? I mean, we're not measuring the muscle index, which is initially what the GFR, and assume that all Black patients have just a higher muscle mass, right? They're all like these super strong, muscular patients, right? That their GFR has to be higher than white patients. It's obviously completely ridiculous and stupid. But that's the criteria we've used for years, right? That unfortunately did not allow us to give our Black patients the care that they deserve, right? And no wonder why everything is worse for them. No wonder why they don't trust us, right? I mean, there's been many things in the past and in the current day and age that we still do that unfortunately negatively impact them. And I'm happy to send this article or this algorithm list to any of you if anyone is interested. So again, are we, practicing really evidence-based medicine here, or are we just looking at patients oh, you're dark enough to be Black, therefore you're Black, therefore blah blah blah. I'm gonna check off all these things, or not, right? Who's, I mean, if you're from, I don't know, from Australia and you happen to be one of the, indigenous Australians, I mean, they're very, very dark skin. And if you're African American or African, I mean, does that mean you're so different that then we have to treat you differently based on an algorithm? I mean, to me, that's just, this notion is completely ridiculous, because we ourselves, nobody understand what race is. And for us doctors to just, sit out here and say, oh, 52-year-old female, Black female, Spanish, I mean, why does that really matter, right? Why does that really matter? So that's that. I don't know if any of you guys have heard about this, but this is, again, modern day. This is Serena Williams, the famous tennis player. She almost died after her second pregnancy in the hospital. She had a PE, again, a preventable reason to why Black women die in the hospitals. She had a PE. She had a history of a hypercoagulable disorder. She had a known history of it. She went into the hospital to deliver her second baby, and she developed a PE. And she told the doctors, I think I have a PE. And they're like, no, you don't have a PE. And essentially, they almost really tried to dismiss her symptoms, and they called her oh, whatever, you're just freaking out after the second baby. But she almost died. She had a PE. She just had a C-section, so they had to heparinize her, start bleeding again, and she almost died. And this is somebody who is super famous, super wealthy, probably was at the top-notch hospital in the United States, and everybody knows who she is. And she was still not spared from these disparities that many of these women have to go through. At Harvard, they decided to, and again, this is because I think the New England Journal of Medicine, I think Mass General and the Harvard, the whole area, I mean, this is where, the New England Journal of Medicine really comes from. But, they formed a committee in 2017 to evaluate structural racism practices at Harvard, right? At, Mass General Hospital. And they published about how admissions to the cardiac service was predominantly white, and that Blacks and Latinos were selectively admitted to medicine rather than cardiology. I mean, they just, this is, again, published from their website. I'm not making these things up. This is not an emotional statement, but they have acknowledged the racial implications, the racial practices that they were doing at their own services. Basically, the cardiologists wanted the patients, probably they thought would have better insurance, better family support. Again, they thought, it was never really, right? And they formed this committee. This committee was going on for 3 years to evaluate these things, and they came up with the decision that yes, we are not doing a good job of putting the patients where they belong, right? So, they're obviously reevaluating their admission criteria and what have you in order for them to do a better job for their patients. And, and obviously the textbooks, we all know about this, but, I mean, I don't know. I don't know what eczema looks like on a dark skinned person because I've just never seen it in a textbook. And unfortunately, this is becoming a thing. I know a lot of people are talking about better representation in medical textbooks. I haven't seen it yet. Hopefully we see it in the near future where people of different skin tones are represented in medical textbooks. So for us doctors to be able to make better assessments and better decisions based on that. So, has anybody, if anybody would like to participate or share or say anything about this, I think it would, Dr. Anjuli just, sent us an article. Yeah, anybody has ever had an experience that they have witnessed, an implicit bias taking place or have participated in it, not willingly, or I would love to hear your stories if you have any. No one, everybody's, and again, well, that's why it's an implicit bias. It's because we don't know that we're doing it. But
experience I want to share.
Please.
I had a patient in, that she has metastatic cancer, breast cancer, and she has a lot of pain because of the cancer, and she is in a point in which she is so frustrated with the system that she was just saying that the staff was very racist with her and everything. And I think it's because of the past experiences she had, because she was going in and out of different hospitals. So she's just frustrated about it. Like, because of past experiences, she's thinking that our staff was also being racist with her. She even called the cops once. I was the I was the witness when the cops came by. But yes, she has PTSD as per psych, and she also has kind of a personality disorder. But I think the bias has contributed a lot to this psychiatric condition she's having. Yeah.
Yeah, I mean, this is, this, unfortunately, we see this all the time, is that all of a sudden we become the pain medicine police. Like, we must, war on drugs, like we must control the opiates. And it's like, this woman is with metastatic cancer, she's gonna die, right? And then yet we're just sitting here like, so, oh my God, like we can't prescribe opiates because opiates are the devil, because, blah, 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 blah. And it's just like, I'm not really sure if it's all that necessary. I mean, I think you have to be cautious, but I don't think that we as doctors, one, are trained to do a good job at assessing pain and treating pain appropriately. And two, we, a lot of it is our implicit biases. Becomes like, oh, is she in pain, or is she just like being histrionic and she wants porn medicine? And it's just like, sometimes you just have to really think about, is this the fight you want to fight today, or do you really want to get objective about things a little bit more? I mean, but I, this pain situation I see all the time. I mean, patient comes in, metastatic, bone cancer. It's like, oh, give them Tylenol. It's like, why? Like, who died and made you the pain medicine police? Nobody, really. So give those patients the medicine that they deserve. Like, they need pain medicine. Let them give them pain medicine. One of the stories that I will never forget, and this is just, again, when something like this happens to you, you're like, is this really happening, or am I just imagining things? But, I had a strong team of residents, one of this is a couple of years ago, excellent, top-notch resident, amazing. I can't really say anything bad about him, right? And, I had two interns, both males. The three, I happened to have a team of 3 white doctors. And we had a patient that came in for, she's cocaine user, I guess. I thought that's the history it said. 49, Black female, history of cocaine abuse, that came in because of weakness, right? And patient is difficult, didn't want to give a history, therefore the history is, no, it doesn't exist, right? So, we went in to see her, and her blood pressure is like 200, her Utox is negative, And, you know, she's sitting there, she's like, I can't walk, I'm limping on one side. And, you know, when I talked to her, she gave me a pretty good history where she was like, you know, I was fine, and then I wasn't, and I have a headache, and I can't walk. I feel like I'm dragging my leg. And I'm like, okay, well, sounds like, you know, and I'm talking to my resident, I was like, well, it sounds like she's having a stroke, or she had a stroke. And he's like, no, but she's a cocaine user. Like, but her Utox is negative, so it doesn't matter if she's, oh, he's like, but she could have had it and it cleared. I'm like, yes, but her blood pressure is 200 and she's telling you I'm weak. And my exam, I mean, I'm not the best neurological exam person, but I was like, the exam wasn't like, I wasn't really excited about it, but she was like, notably, she was getting up and walking. She wasn't trying to like lay in bed and be all dramatic. She was getting up and walking, but you can see she was not walking well. I mean, she was dragging her foot, or like trying to pick up her foot. I forget exactly what was the finding. And I was like, well, let's just get just get a head scan. Like, why have we not scanned her head, right? I mean, why not, right? Okay, where's the head scan? Where's the EKG? Where's this? Where's that? Nothing was done. You know, lo and behold, you know, this woman not only had an acute stroke, but also had new AFib that went missing, and, you know, obviously had an embolic stroke from her AFib, not from her cocaine. You know, ended up with a cardiomyopathy from hypertension. None of the stuff that she had was related to her, I don't know, 1 or 2 times snorting coke, I guess, and telling somebody about it. But yet everybody was just like, oh yeah, you know, I remember like everybody saw her as like, you know, the cracked out black woman kind of thing. And everybody was like, oh yeah, whatever, cocaine kind of thing. And, you know, she was like thrown on a medicine floor with no telly, with no head CT scan, with no EKG, in fact. And, you know, oh, it's just cocaine. She's weak because of cocaine. When her Utox was like negative on admission and her blood pressure was like 200. And blood pressure obviously came down on its own a few days later. I mean, this woman had a stroke, but yet we were so blind. We were just choosing to be blind to everything she presented with because of our bias about what this woman, I mean, again, she had a personality, you know, she's all over the place, hot and cold, up and down, this and that, you know, but her story was very clear and it was concise every time she would tell it. And if you factor out her personality, which again, I'm not trying to be her best friend, I'm just her doctor, her story was pretty concise. And she was telling, I mean, everything she said talked about how she just had a stroke. But yet we were so blind to it. And again, this was not a lazy, this was one of our top-notch residents. And I don't think he's a bad guy or anything like that. I just simply think they were just so blind to everything in front of them because of the implicit bias that they have. And we all have it. Every single one of us have it. And I think if we don't talk about it and we don't confront the problem, I think we all tend to slip into the cracks and do things that unfortunately, you know, will hurt our patients. You know, it's whether emotionally or physically. I mean, it's both are valid things. And with that, I suppose we'll get into things that we can potentially do to sort of help our, you know, to sort of change the status quo. The CDC has a list of things, and I didn't want to come up with these lists from any other place. And I wanted to, well, I guess the CDC is not the best anymore, but that's okay. We'll go by this one. It's not a bad list. But, you know, the moral of the story is that, you know, Black patients do better when the doctor is Black, and that most likely translates because the biases are eliminated when the patients are seeing somebody that looks exactly like them, right? All these biases that we have, I mean, not all, but the majority or some of these biases are eliminated. And that just doesn't apply to Black patients. That probably applies to Hispanic patients, Middle Eastern patients, Indian patients, just the biases are gone or a lot of them are eliminated. So what is it that we can do to do better? I think we need to have a more diverse doctor/nurse patient populations that take, you know, and that doctor/nurse population should reflect the communities that they serve. We should be encouraging our doctors to talk about equity, to talk about social justices, and not just make it, you know, sort of a side thing. You know, we focus so much on cardiology and oncology and this and this and that, but yet all of the stuff that we do is still not translating to better care for a certain patient population. Therefore, this type of work should be, you know, something that people get paid for, should get something that people get time to do, and should be emphasized, right? It shouldn't be just a hobby kind of thing, which unfortunately is a situation for many of the people that do this type of equity work or, you know, social justice or racial biases. A lot of people do it on the side because it doesn't necessarily, you know, no institution really wants to give you time to do this kind of work because they care more about other things that make them money, which is silly. But yeah, but many other things. And one of the things that I am personally very passionate about is, you know, I mean, you know, why is it that we have such little Black doctors? Why is it that we have such little, you know, Hispanic doctors? It's because our medical school criteria are very, you know, focused and catered towards the elitists, people who can afford to do certain things and have been in families that allow them to do certain things. You know, when we hire doctors, you know, again, it goes back into the same things, less of these, you know, minority doctors, and we ended up having, you know, doctors that don't represent the communities that we serve, and back to the, you know, the emphasis on this work that many institutions does not give the doctors or the people that want to do the work the time and money to actually do that work. So there's a lot that can be done, and hopefully it gets done. It's, you know, it's picking up a lot of traction and a lot of momentum, so hopefully it keeps going. But, you know, there's a lot of work that does need to be done. I guess one of the things that Sinai has done recently is remove the African American race from the GFR calculation. So you can hopefully go to bed knowing that that's the case in our institution. So our patients' GFR does not account for their race, which is great. But obviously there's a lot more that needs to be done. And, you know, just the take home message is that our Black patients, you know, are, you know, unfortunately, we do deal with an impoverished patient population, underrepresented ones. We don't see the educated, the wealthy, we see the patients that most of them live in the subsidized housing or they have not been educated. It's, you know, I think the education level in our hospital is that of a third grader, basically an eight-year-old. So those are the kind of patients that we see. And when they happen to be a minority or women, I mean, it's multiply all the odds of how bad things can happen to these people, and they do. And, you know, many of these things, unfortunately, we do unintentionally, but it's really important to always remember the facts and remember the reasons why many things are the way they are. And nothing anymore should be because it's the way, you know, the way we used to do it. I think that statement should be banned forever. And we should always be thinking critically about the things that we do and the actions that we take, because it does impact people's lives. And back to the question that I asked, and, you know, do Black people have thicker skin than white people? And the answer is no, they do not. Yet when they surveyed patients at the University of Virginia, they surveyed patients and they surveyed medical students and residents, 58% of lay public said yes, they do. And 25 to 40% of students and residents said yes. So, I mean, this is a simple question, and we are still, we still think that they have thicker skin. And again, what does that mean? Are we going to give them less pain medicine? Are we going to think that they're, you know, it can mean so many things, but the fact that we think that they are different, their skin is thicker, to me is mind-boggling. But again, to answer the question clearly, no, they do not have thicker skin. They have the same skin structure. And with that, I end. If anybody has any questions, I'm gonna open this link here. Feel free to answer, put it in the chat, or I guess email me.